Right, I'm going to sort of recap some of these studies and some of the other data very quickly, cut out some things that have already been mentioned. So here's some disclosures, and then off-label use of devices will be discussed. So we've talked about venous obstruction here. It's a condition that affects the deep veins, can lead to long-term disability. These can be categorized into iliofemoral, iliocaval, or cable-only disease. And we talked a lot about the iliofemoral studies for the IDEs, but these are also subcategorized in those studies as acute iliofemoral DVT, non-thrombotic or nivel lesions, and then chronic PTS patients. And we know that more and more patients are being stented in basically all the vascular beds. So just a picture of the patient of the CT. So I'm going to kind of skip all the IDE studies that were already discussed, but kind of talk about the two systematic reviews. This is one from 2020, where the IDE studies, several of them are included. And so when you look at this, this is a look at the retrospective sort of experience with using wall stents, Proteges, Illuminex, smart stents, kind of all the standard non-FDA approved venous stents, and then also including the patients that had FDA approved venous stents. And so it was a systematic review of 3,812 patients. Standard stents, what they called standard was in 3,000 or so, and then 740 patients with the venous indicated stents. These patients all had, in all these studies, had different, differing quality of life measures, venous severity scores, Villalta, Civic. They were all used at different time points at different, between the studies. They also characterized patency in different ways. So it's important to note that some use ultrasound, some use phenography, some use CT. And so, and really we don't know, that we don't have a consensus across all of them. But the few things that we do know is that standard stents when you take all of the studies together had about a 71% primary patency rate, primary assisted patency of 89%, and secondary patency of 91% at 23 or about 2 years out. And this is sort of predominantly the wall stent and other nitinol stents used in non-venous indicated stents. When you look at the dedicated venous stents as a whole, so that's 78% patency when you include all the PTS, acute DVT, and nivel lesions. And there was significant weighting towards the PTS patients, as you saw in several of the presentations that many of these lesions are longer. Many of these patients, all the studies had about a third patients or so that had PTS, and so that is going to affect that, skew the results towards that side. But overall, dedicated venous stents had a patency of about 96% in nivel patients and 73% in PTS, which got cut off. Sorry. There was a further systematic review that came out earlier this year, and I think Kush mentioned this. This one actually looked at about 5,000 patients, so it's further includes all the patients in that prior study and then additional patients. And so this is about 1,400 nivel patients, acute DVT patients of almost 1,000, and then PTS there was nearly 3,000, and those were separated into patients who were stented above and those below the inguinal ligament. And again, this looked at the outcomes that were reported, but included technical success, patency at 1 year, and symptom relief. And this looked at both the dedicated and off-label venous stents. So what they found is that there's significant heterogeneity between studies reporting outcomes in PTS patients. So again, Villalta, VCSS is used differently in different studies, not at all in some studies, and they just describe venous claudication. The primary and cumulative patency at 1 year, again, as we've discussed, is about 95 to 100% in nivel patients, about 90 to 95% in DVT patients. And then when you look at the PTS patients, it's approximately 80% in many of these studies. And so above the inguinal ligament, it was 77 and 94% in primary and cumulative patency. And across the inguinal ligament, which was discussed earlier, is about 78 and 94%. So there was not a significant difference across those patients. Finally, there was also insufficient data to compare patency outcomes of dedicated and non-dedicated venous stents. So they were looking at the large wall stent group, essentially, and comparing it to the dedicated venous stents and looking at the acute DVT subgroup as a whole. Again, these patients had improvement in venous claudication type symptoms, but about 83% of PTS patients and most of the 90% or so of the nivel patients, and ulcer healing occurred in about 80% of these PTS patients, and many of the patients with nivel did not have ulcers. Specifically to iliocaval stenting, since this is not looked at in any prospective study, as there's no through iliocaval or IVC approved stent. There's just some retrospective reviews that have looked at this. And again, the findings are a fairly high technical success rate, although it's lower than the technical success of an iliofemoral stent placement, which is closer to 100%. 4-year primary and secondary patency rates are much lower for iliac vein recans as well as IVC recanalization. So we're talking at half the rates. There was a European study looking back as well, and they found very similar numbers at 10 years. And then this is a study that we had performed, which also finds that there's a high primary assisted and secondary patency rates over time. But again, our anticoagulation regimen is fairly aggressive. And so we have that, but we also have a higher bleeding risk as well. So, and we know that. And I think I skipped out a Cush's study that also had looked at iliocaval reconstruction with IVC filter retrieval and was similar. So just to wrap up all of the different studies, we know that there's a lot more stents that are being used. They have a high technical success in all patient populations with varying 1 to 3 year patency, as we've heard, with lowest being in PTS patients, and that's around 80% at a year. Clinical outcomes are not consistent among the studies or operators, and therefore difficult to compare and assess because nobody's really using the same system. They're not using it at the same time point, and it's really difficult to kind of combine and compare studies. And there was also a difference between all the studies in the antithrombotic therapies. I think only the Vici or the Virtus studies actually reported out their specific anticoagulation regimen, or at least focused on it. And so it's also that it may affect patency and clinical outcomes, as we talked about earlier. So we really don't have a great answer for specific, stents that say which one's better. They're all kind of very similar. And we do know that PTS is harder to treat. Patients with complete iliocaval occlusions have worse outcomes over the long run. And I think it's important for us to continue to study this. Again, this would be a very big plug for the C-TRACT study because these patients with PTS, which is a large group of these patients, should be considered for the randomized control trial so we can actually further assess how these affects these patients, and we can do it in a rigorous manner. Just trying to wrap up quickly. Thank you.